somewhere else to give grand rounds, and that's what we have this morning. Amy Hildreth is a graduate of the University of South Carolina Medical School as opposed to MUSC. She would want you to know that, I think. But we were able to recruit her here to do her residency training. Along the way, she did her critical care fellowship, and then when finishing, moved over to Winston-Salem to Wake Forest University for the program there. Along the way here, she was an outstanding resident, gave a lot of talks from this podium, and also found time to pick up a really nice husband along the way, and they now have twin boys that have started to school, I think. That happened since she left here, the boys at least. She worked in trauma critical care and acute care surgery at Wake Forest and coordinated the medical student program for a while, and then has now moved up, and she is the program director of the general surgery residency there, which is one of the really outstanding programs in the country. So we're proud of her on many fronts, but we're especially proud that you came back to give us a talk today, Amy. Welcome back to Chattanooga, and we're looking forward to your talk.
Thank you very much, Dr. Burns, for the kind introduction. It is really an honor to be asked to come back and give grand rounds here, and I'm more than just a little relieved to be standing here today giving grand rounds instead of standing here giving a Thursday morning M&M presentation, as all the residents in the crowd are familiar with. But I will tell you, residents and students that are here, that I realized once I left just what a wonderful place to train and to learn the practice of surgery this place is. I really, everything that I do today and the way that I train residents now at my program is very much shaped by the things that I learned here, and so you all are very fortunate to be sitting where you are. So today I'm going to talk about something that's a little bit different for a surgery talk. Dr. Barker asked me last night at dinner whether or not it was going to be a fun talk, and I didn't exactly know what to say. I think this is a necessary talk, and a talk hopefully that will open your eyes a little bit, but it's meant to make you maybe a little bit uncomfortable, because I know that that's sort of what I was when I started to learn more about this topic. So we'll talk some about implicit bias. No disclosures. And today we're going to talk about how to describe implicit bias, what the implications are of bias for our surgical work, and we're going to talk about some solutions. So I first started thinking about this topic in 2017. I went to the Academic Surgical Congress, and I heard this talk by the AAS president-elect, Caprice Greenberg, and she talked about sticky floors and glass ceilings, which was a talk about the disparities in advancement, career advancement in medicine between women and men. And as part of her talk, she had this quote about implicit bias, and she said, "We all have implicit bias. Until we recognize this, embrace it, and identify the tools that we need to mitigate the impact of our biases, we are never going to be able to solve these problems." And that really struck me, because I think I had always thought about bias as something that existed out here. You know, that bias was something that other people had, that I was open-minded and egalitarian, and I think I was, until that point, pretty unaware of the biases that I held. And so as I started to think about this, I thought back in my life, and I'll take you on this journey with me. And so you might recognize this third grader. This was me in third grade. And I had this teacher named Mrs. Suddeth. And so Mrs. Suddeth gave us these exercises to do in class where she'd give us what's called a story with a hole. And so she would give us a story that was missing one crucial piece of information and sort of ask you to solve the puzzle. And so some of you may have heard this one before, some of you not, but here it is. A father and a son went in their car for a road trip, and they got in a car crash. Father died, and the son was badly injured. He needed surgery, but in the hospital, when the doctor comes in, the doctor says, "I can't operate on this boy. He's my son." So who's the doctor? Who's the doctor? Mother, right. So, you know, I think that's easier for us to answer because some of us have heard the riddle, and because there are lots of female surgeons or women who are going to be surgeons in the room. But when I was in the third grade, I had a really hard time answering this question. And it's not because I had any preconceived notions about whether or not women could be surgeons. It's just that I had all these implicit biases based on the influences around me. And interestingly, when I gave this talk in Winston-Salem, one of my female colleagues, who's a pediatric surgeon, has been on our faculty for 5 years, came up to me afterwards and was really embarrassed because she had never heard this riddle before, and she had to think about it for a second to actually solve it. So today we're going to talk about what these implicit biases are, about how they affect our patient care, how they affect how we educate residents and students, and how they affect us as we move on in our careers. So what are implicit biases? What are we talking about here? They are attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. And if you don't get anything else from this talk, I want you to understand that these are not biases that you hold explicitly. These don't reflect the way that you want to live your life. They are unconscious attitudes and stereotypes that you hold without even knowing it. So they're not prejudices or explicit biases. I'm not afraid to call those out where they exist, but this is not what we're talking about today. And they're not a reflection of your morals. Everybody has implicit biases, as you'll see, and it doesn't make you a bad person. And they're learned from culture, from what we see around us, and often they conflict with the beliefs that we consciously endorse. And at times they're even directed toward our own group, as you'll see later. They predict behavior in some cases more accurately than explicit measures. They can even be detected in infants. And so why do we have these? And I think the root of this is in our cognitive processes. They're thought to be two types of cognition. There's reflective and automatic cognition. And so our conscious beliefs are controlled by our reflective cognitive functions. And so, like Mr. Spock, they're slow, deliberative, well-reasoned. Our automatic cognitive functions can be illustrated by Mr. Simpson here. So these are the effortless, emotional, uncontrolled, and importantly, fast decisions. And you'd think that we would all do well to function all the time like Mr. Spock, right? But if that were the case, we couldn't function on a day-to-day basis. The type of cognition that allows you to walk from your office to the operating room while simultaneously talking on the phone to a resident or a student about a patient is your Homer Simpson cognition. Because if you were reflectively thinking about the way to the operating room, you wouldn't be able to get there while doing something else. So just an illustration of how these biases work and how we function. So if I tell you I'm going to make a sandwich, and this is the first ingredient, peanut butter, what's the second ingredient? Jelly, right. So how did you know that? Most of you in this room don't know a whole lot about my food preferences or whether I have any allergies, or maybe those of you at dinner last night know a little bit about what I might like to eat, but nobody knows anything about whether I like peanut butter and jelly. But all of your experiences that you've had in your life led you to have a bias that when I said peanut butter, I was going to say jelly. So these biases can be really adaptive and can help us get through life, and they can be about really common things. They come from cultural influences. First of all, our social interaction with our parents when we're kids and with our brothers and sisters and people around us, from our education in school, the news, from media. And there's a social scientist named Dolly Chug, who's at NYU, who describes these as this fog we've been breathing our whole life. The problem is that the fog doesn't always reflect reality. So this is just an example. This is a table of representations of different kinds of people holding different kinds of jobs in certain sectors in family films and primetime programs. And now I'll direct you to look at the doctors and healthcare managers, that 78% of the doctors and healthcare managers in family films and 70% in primetime programs are men. Whereas we know, and that's just not the reality in the life that we live, but the media that we see doesn't accurately always reflect the reality around us. And part of the problem is that these biases form a sort of blind spot, that we're unaware of them. There's actually a book that I would recommend to you if you're interested in reading more about this, called Blind Spot: Hidden Biases of Good People. And in this book, they say that receiving the benefits of being in the in-group tends to remain invisible for the most part. And that's why members of the dominant or majority groups are often genuinely stunned when the benefits they receive are pointed out. blind spots hide both discrimination and privileges, and so neither the discriminators or the targets of discrimination, neither those who do the privileging nor the privileged are aware. And so, to paraphrase, my boss, Dr. Wayne Meredith, always says, "A fish can't see water." And so basically, you can't see these things because you're living in the midst of them. And so if we can't see them, how do we measure them? In 1998, here's a group, Greenwald and colleagues, who sought to find a way to measure these implicit influences on our cognition using a test. And the problem is, as we described, that these implicit biases are going to be different than what we would answer on a survey, and we're unaware of them ourselves. And so it's hard to really get at them without doing a specific test. And so they developed an implicit association test. And I'll show you some pictures in the following slides of what that looks like. Some of you may have taken the test. It's freely available at the implicit. I have a link to the website at the end of the presentation. It's a Harvard website where you can take these tests. But they started out by taking flower and insect names and having the participants attribute pleasant or unpleasant words to flowers and insects. And they found that it was easier for people to attribute pleasant attributes to flowers and unpleasant attributes to insects. And they found that because they looked at the differential time to response to attribute these attributes to the concepts, and found that people were able to more quickly make pleasant associations with flowers and unpleasant associations with insects. And they went on to do this test looking at all sorts of other things, including race and gender, as you'll see later. So the IAT procedure seeks to measure implicit attitudes by measuring their underlying automatic evaluation. So this is what the test looks like. You just use a keyboard, and there's an E and I key, and it'll give you an attribute or a face. Like in this case, this is the race implicit association test. And so it gives you a face or a word, and you have to press the correct key. And it measures how quickly you do that. And there are 7 parts. The first is just to tell whether you can correctly associate each with the appropriate key. And then they start to combine these attributes with, in this case, black or white faces. And then midway through the test, it switches. So in this example, it's bad or black people, good or white people. And then midway through the test, it switches so that bad is with white people and good is with black people. And it measures how quickly you make these associations. And it turns out that in the population of people who've taken this test, and so they have 3 million scores now for the race test, that the vast majority have slight to strong automatic preferences for European Americans compared to African Americans as scored by this test. When doing a similar test, looking at associations between men and careers and female with families, you see the same type of association, that most people who take this test, over, 800,000 scores, have a slight to strong automatic association of male with career and female with family. And so how might these biases we hold affect our ability to solve problems? So in our work, we deal with complex problems all the time. And there's this concept of bounded rationality, which is actually an economics concept. It's a Nobel Prize-winning economics concept that says that our ability to make decisions rationally is bounded by our cognitive limitations, our information that we receive, and our time constraints, because there are many, many pieces of information coming at us all at one time, and we can only process a certain number of those. And so the decisions that we make are limited by the time that we have to process that information and the amount of information, as well as our cognitive abilities. And so putting all these things together, we sometimes come up with suboptimal decisions. And so what's the evidence about bias in patient care? And as a caveat, I'll talk a lot today about gender and race, because that's where the data are. But there are many other areas in which you can hold biases that may affect your patient care. These are just the most commonly studied. Disparities do exist in surgical care. We know this. That they've been reported in every field, from neurosurgery to vascular surgery, general surgery, colorectal surgery, transplant, you name it. There are disparities, most notably looking at race, but also gender. And where do these disparities come from? So in this graph, you can see that the quality of healthcare that's been described for non-minority folks is higher than that minority folks receive. And the difference between those is made up by the clinical appropriateness and need, and also patient preferences, the ecology of healthcare systems and environmental factors, so the social determinants of health, and discrimination, biases, stereotyping, and uncertainty. And so the first, clinical appropriateness and need and patient preferences, that's probably something we can't do much about. But the second two contribute to what's called a disparity. And the one that I think we as clinicians can most influence is discrimination. So looking at some naturalistic studies, just where disparities are documented in their natural environment without performing an intervention, there have been demonstrated that there are outcomes that favor white patients in single centers looking at transplantation for hepatocellular carcinoma, that they're more likely to get limb salvage and peripheral vascular disease, and more likely to get coronary artery bypass graft for MI and angina. The Surveillance, Epidemiology, and End Results database says that there are lower rates of surgery for brain tumors, squamous cell cancers, esophageal adenocarcinoma, and non-small cell lung cancer with equivalent disease stage in Black patients. And interestingly, in rectal cancer, Black patients are less likely to receive adjuvant treatment or sphincter-sparing procedures. So one of the first experimental studies looking at this was an article in New England Journal of Medicine by Schulman and colleagues, where they used mixed media patient scenarios, and they had patients with chest pain with various sociodemographic characteristics, and they asked the participants to both estimate the risk of disease and also prescribe a treatment. And they found that even when adjusting for the same predicted estimated risk of having disease, that with white males being the reference ratio of 1, that the cardiac cath odds ratio for women getting a cath with similar scenarios was 0.6, for Black patients was 0.6, and for Black women was 0.4. And so pretty big differences when the only thing in the scenario that varied was either the sex or the race of the patient. A subsequent study, also in medicine patients, looked at was a clinical vignette of a patient presenting to an emergency department with an acute coronary syndrome. And this was followed by a questionnaire and 3 implicit association tests, the tests that I described to you earlier. The participants were 220 internal medicine and emergency medicine residents in Atlanta and in Boston. And they basically were randomized to receive either a Black or a white patient in their vignette. And they found that their IATs revealed implicit preference favoring white Americans and implicit stereotypes of Black Americans being less cooperative with medical procedures. And as their pro-white bias increased, their likelihood of treating white patients and not treating Black patients with thrombolysis increased. So what about surgeons? Do we have biases? Before I started looking at this topic in more depth, I thought I would like to think not, but actually it's true. We have biases as well. This is a study by Hyder and colleagues. They surveyed EAST members, so members of the Eastern Association for the Surgery of Trauma, and they had them complete surveys about their explicit race and social class preferences. They completed clinical vignettes with trauma and ACS clinical questions, and then they completed race and social class IATs. They had 250 members participate, and 79% of those people, as you might expect, said that they had no race preferences, and 55% said that they had no social class preferences. But you can see, so the gray bars, the light gray bars up there are the what people reported, and the black bars were what they found in their IATs. And as you might imagine, despite reporting that they had no race preferences and no social class preferences, that 73% of participants had IAT results indicating unconscious preferences toward white patients, and 90% actually had preferences for upper class patients. But interestingly, the IAT results did not significantly correlate with clinical assessments. However, surgeons who reviewed the vignettes of the Black patients were more likely to believe that there was a hidden history of alcohol use in a post-splenectomy trauma patient with Black patients compared with white. And then they were also likely to believe that a patient posed a threat to himself or others if the presented patient was Black versus if the patient was white. Hyder and colleagues did a similar follow-up study, which was a single institution study looking at a variety of different specialties. They looked at 215 clinicians at a single institution. They were all associated with the care of acute care surgery problems, and they found similar findings. They included residents and interns in their study, and they found that, again, people said they had no bias, but that their IAT results showed that they did have some bias as measured by the test. However, again, the biases were not significantly associated with decision-making. So does this mean that we're off the hook as surgeons, that we may have biases, but they don't affect the treatment of our patients? I think it's hard to say. I think we don't have the data yet. It's different to sit at your desk and use your Mr. Spock brain to solve a clinical vignette versus take care of a patient in a clinical setting. And I think we still don't have a lot of answers that account for the disparities in care that our patients receive. So another factor that's been shown to influence how biases affect our decision-making is the effect of cognitive load. This study was a study of VA primary care physicians, and they looked at their decisions to prescribe opioids. And again, it was a web-based study with vignettes, but they also added kind of an interesting twist, and they added another sort of test along with it that placed the physicians under high versus low cognitive load. And so male physicians were less likely to prescribe opioids for Black than white patients under high cognitive load, and more likely to prescribe opioids for Black than white patients under low cognitive load. And female patients were more likely to prescribe opioids for Black than white patients in both conditions, but there are greater racial differences under high versus low cognitive load. And I think there are several studies out there, including this one, that show us that the amount of patients that we're seeing and the complexity of our patient population can contribute to the effects that our biases have on our patient decisions. There are also some biases inherent in the interpersonal relationships that you develop with your patients that can influence outcomes. There are several studies, including one where VA physicians were found to be less likely to initiate conversations providing information to Black patients than to white patients about coronary angiograms. And on the flip side, there was a study where they measured trust in providers after they met with their healthcare providers, and patients were asked beforehand what their confidence was in their healthcare provider, and then after what their confidence was in their healthcare provider. And they found that there was decreased trust in providers after encounters for Black patients compared with white patients, even when controlling for patient-provider racial concordance. And they also found in a different study that physicians have been shown to be more verbally dominant with Black patients and less patient-centered, more negative in affect, even controlling, again, for patient-provider racial concordance. And so these biases aren't just limited to race and gender. This study showed that bariatric surgery patients' outcomes are actually affected by their perceptions of weight-related stigma. So they looked at post-bariatric surgery patients, 300 post-operative patients, got quantitative data, and then went back and looked at qualitative interviews with 35 patients over a 4-year period. And they found that if patients had experiences and perceived stigma about their weight loss, that predicted worse dietary adherence even after the weight was lost. On the qualitative side, the patients didn't recognize that this was happening. They couldn't articulate that, because I perceived this stigma, I didn't have good dietary adherence. And healthcare providers routinely explain this just as poor compliance. Another area where we may run into problems with bias is when there's ambiguity. So ambiguity in the correct treatment path may contribute to disparities in care. We may find that expression of pain and other symptoms may vary among cultural groups, causing us to have problems even diagnosing or choosing the correct treatment course. These variations may contribute to a lack of understanding between a physician and a patient, and it's been shown that lack of adequate care may lead to lower rates of seeking care in the future, thereby increasing disparities that exist. So what about the folks that we train as students and to be surgeons. So these are two of my residents in the operating room. So you might think that our students, being younger and maybe more open-minded in some cases, would be immune to this bias. And Hyder and colleagues who did the other studies about IATs and providers also looked at medical students at Johns Hopkins. And they looked at 200 incoming medical students at Hopkins and reviewed their IAT results, as well as responses to clinical vignettes, and found similar findings to the previous studies, in that they stated that their preferences for Black and white race were similar, and that they did not have a strong preference for upper class patients. But again, their IAT results showed that they had pretty strong preferences for white patients and also for upper class patients. But again, there was no difference in their responses to the clinical vignettes. And so how about when we're choosing medical students to join our residency program? This is probably the area where the implicit bias literature is the strongest. There's a AAMC webinar and website that I'll direct you to at the end of the talk that actually has a whole lot of data in this area, and this actually could be a talk in itself, and resident and student selection as it relates to bias. But this is one study that I thought was telling. This is racial disparities in medical school membership in the AOA Society. And so this was a retrospective study. It was a single institution, but they looked at ARIS data for people applying at their institution in 12 different specialties. And they had 4,000 applications. About 46% were women. 60% of their medical students that they looked at in this study were white versus 5.8% Black. But when you look at the AOA membership, 71% of the AOA students were white versus 0.7% were Black. And you can see the numbers there for Hispanic and Asian or Pacific Islander students as well. And what they did was look at AOA criteria, and they thought, well, the AOA says that they look for students with leadership and community service and attributes of humanism. And so let's adjust for that and see if, maybe it's just that the white students had all of these characteristics more than the Black students did. And so in the second column, you can see that they adjusted for these AOA proxies and found the same difference, with white males being the reference of 1, that the odds ratio of Black students, as well as basically every other non-white student being an AOA member, was lower. But then they thought, well, maybe they just had better test scores or advanced degrees or had written more papers. And in the third column, you can see where they fully adjusted for basically everything that you could think of that would go into being an AOA student. And it turns out that as compared to white students, that Black students have an odds ratio of 0.16 of being an AOA member. And Asian or Pacific Islanders also had a lower rate at 0.52 odds ratio. What about once students become residents? How do we evaluate them, and is that affected by bias? This study looked at emergency medicine residency training, and they looked at 360 emergency medicine residents, 285 faculty members, over 8 academic and community EM residency programs over a 2-year period. And they actually had 33,000 evaluations of these residents in their study. So the male and the female residents were at the same levels on their milestones at the beginning of their residencies. But the rate of milestone attainment was higher for male residents, and by graduation, the gap was equal to about 3 months of additional training for the male residents. In surgery specifically, Sherry Meyerson, who's a thoracic surgeon, has looked at this, looked at the effect of gender on resident autonomy in the operating room. And I think we all believe in this program, and also at my own, that resident autonomy is a really important factor for training competent general surgeons. And this, I'm sure they believe the same in thoracic surgery. And so they looked at the autonomy in their thoracic fellows, and they looked at 33 residents over 7 institutions, and they used the Swish scale, which you guys may use here, and it rates your autonomy from show and tell to active help, passive help, and then supervision only. Both the faculty and the residents entered a Swish score And they also entered the degree of the difficulty of the case. So faculty perceived that in 56 of 184 evaluations, they gave meaningful autonomy to female residents, so 30% of the time. And 107 out of 292 evaluations, or 36%, they felt like they gave meaningful autonomy to male residents. And so they gave more autonomy to male residents. But what was interesting was that the resident perceptions of autonomy were markedly different, that female residents felt like that 19% of the time they had meaningful autonomy, and male residents felt like that they had it a third of the time. But I think what's even more interesting is when you look at the case difficulty. So on the left is the easiest 1/3 of cases, and on the right is the hardest 1/3. And you can see that the bars are pretty close. So the easiest and the hardest cases, the faculty perceived that they gave the residents the same autonomy. And so, looking at the numbers in this previous slide, you might say, well, the male residents just got more autonomy because they were better. Well, if they were better, then why did the faculty give the male residents and the female residents the same autonomy on the hardest cases? So the easiest and the hardest were the same. The real difference was in the average cases, where there's a little bit of wiggle room about how much autonomy you could give the resident. And I think that's important to point out, and it's important for all of us to think about, because these differences, it didn't really matter whether the faculty member was male or female. These differences persisted despite that. And finally, another thing I think we need to watch for in our trainees is that there is this thing that exists called self-stereotyping. So it was first shown that in patient populations that elderly patients who internalize stereotypes of the elderly that are negative are at risk of declining health. And they've also shown in educational studies that women who internalize gender stereotypes are at risk for underperforming in math and science. And there's this thing called stereotype threat, that those who are members of a negatively stereotyped group tend to underperform when reminded of their group membership. And so if I have this implicit bias that women are worse at math than men, and you remind me of the fact that I'm a woman in some way before I go to take a math test, I'm going to do worse. I think this is really important for our trainees because they may underperform not as a result of lack of ability, but because of the stereotype threat. And so finally, how does this implicit bias affect us as our careers? For the residents, this is going to be important as you go finish training and go on into the real world. And for those of us who make hiring decisions, I think it's also important. So there's some pretty big disparities, both in gender and race and ethnicity in academic medicine. And this is an interesting study where they examined 50,000 faculty in U.S. medical schools, and they looked at graduates between 1980 and 1989, and they evaluated their promotion rates by the year 1997 by race and ethnicity. And after adjusting for cohort, sex, tenure status, degree, department, medical school type, receipt of NIH awards, underrepresented minority faculty remain less likely to be promoted compared with white faculty for assistant professors and also for associate professors. And Asian and Pacific Islander professors were also less likely to be promoted, whereas at least at the assistant professor level. And so there are also disparities in promotion in the gender and gender in the surgical workforce. So this is a slide from Caprice Greenberg's talk that I referred to at the beginning, and you can see that at the end of medical school, graduates are about 50 and 50-50. But then as you sort of move up the ladder, by the time you get to full professor, tenured professor, and dean, that the vast majority of folks who make it to this level are men. And there are a lot of reasons for this disparity. I'm not saying that all of this is bias, but I think it's a significant factor. And as you'll see, it factors into our decisions as we're hired and as we're hiring. So this is an interesting study done in the labor market, so not in medicine, but and the study title was, Are Emily and Greg More Employable Than Lakeisha and Jamal? A field experiment on labor market discrimination. And so what they did was they put out newspaper want ads in Chicago and Boston, and they used resumes that were low or high quality. They had sort of a standard resume for each category. And the only thing they changed on these resumes was that they gave one set white-sounding names and one set African-American sounding names, like Lakeisha and Jamal. And they measured just callbacks for the resume. And there was a 50% gap in callback rates favoring white-sounding names. And white applicants got more credit for higher quality resumes, and African-American sounding applicants actually got a worse penalty for the lower quality resume. There was a similar study where investigators sent similar resumes in a lab manager job and changed only the name to be male versus female. The male applicants were judged to be more hireable, and interestingly, starting salary was $4,000 higher. Even if we were the boss, this bias still applies. In one study, respondents who say they have no explicit gender preference were willing to take $3,400 less in salary to work with a male boss. And so I think when we're looking at who we're going to hire for a job, the applicant pool is really important. There's a study done in 1980 where they had 100 men and women evaluating a woman applicant for a managerial position, and they varied the percentage of women in the applicant pool. That's the only thing that they varied. They gave them a score from 1 to 9, 1 being the lowest, 9 being the highest. And the proportion of women in the pool changed the female candidates' rating and whether they were recommended for hire. So you can see here the results. So again, scale 1 to 9, 9 being best. And as they varied the proportion of women in the pool, at the lower end, the women had lower ratings in terms of their qualifications and whether they were recommended for hire. But once you got over 25% women in the applicant pool, it's the only thing they changed, the scores got a lot higher. How we talk to each other is different when we look at a lot of factors, including gender. And this study looked at speaker introductions at internal medicine Grandrounds and the forms of address and how they revealed potential gender bias. So when women introduce other women at Grandrounds, 97% of the time they use a professional title, such as doctor or professor. When female introducers introduce male speakers, 95% of the time they used a professional title. Men in general were a little bit more casual. They used first names, 28% of the time or so. But they still used, when they were introducing other men, they used titles 72% of the time. But when men were introducing women, they used professional titles only 50% of the time. And you can see this at national meetings if you listen carefully. When people are discussing a paper or introducing a speaker, that sometimes they'll use a professional title for a man and a first name for a woman without even realizing they've done it. I've done it before. It doesn't make people bad or wrong. It just reveals that our language, without us knowing it, reveals the implicit biases that we hold. So I'll see if I can get this video to work. Uh-oh. Sorry, the computer is logged off. Does anybody know the password? Okay. Well, we'll come back to it. Let's see if I can get it to work on the screen. Nope. Okay. We will come back to the video in a moment then if we can get it working. One of the more interesting studies done in terms of labor market actually labor market in surgery actually doesn't come from the surgical literature. This comes from the economics literature. This is actually Heather Sarsons, who is a postdoctoral student in economics, and she was at Harvard. I think she's now at Toronto and doing some work. And she looked at the Medicare carrier file, which is a 20% random sample of fee-for-service claims of Medicare beneficiaries between 2008 and 2012. She supplemented this data with the Physician Compare National File and the Dartmouth Atlas of Healthcare, and looked at PCP's referrals to surgeons. And she found that PCPs view patient outcomes differently depending on the performing surgeon's gender. So primary care physicians become more pessimistic about a female surgeon's ability than males after a patient's death, indicated by a sharper drop in referrals to that female surgeon. However, primary care physicians became more optimistic about a male surgeon's ability after a good patient outcome, indicated by a larger increase in the number of referrals to the male surgeon. And this is really the kicker of the study, that primary care physicians changed their behavior toward other female surgeons after a bad experience with one female surgeon, becoming less likely to refer to new women in the same specialty. And there's no such spillovers to other men after a bad experience with one male surgeon. So I feel like I've given you a lot of information that says we all have these biases. They affect the way that we educate students and residents, treat patients potentially, and are evaluated and evaluate for hiring decisions as well as promotion. And so what do we do about this? How do we overcome this unconscious bias? I think the first step is really just to become aware of it. And so I would encourage all of you, when you have some time, to take some of these implicit awareness tests. It doesn't take that long. You go to this website and log in, and then you can take the test. There are several of them. There's a race IAT, there's disability, there is women with career versus family, women with science versus liberal arts. There are a number of them, and it can be actually really informative. I will also warn you that you may find out that your answers are different than you think they are, and that different than you would like them to be. So I'll give you a personal example. So these are my scores. So I am a woman. I've been a surgeon for 10 years. I try pretty hard to promote women in medicine and women in sciences. And yet when I took the test, I had a strong automatic association for male with science and women with liberal arts. You know, I can't explain it. That's not how I consciously believe and not how I consciously would like to act. But it's there, and I think it probably affects my interactions with other people. Here's another interesting one, more of my results. So, I'm a surgeon, I work full time. My husband stays at home with my kids. And yet when I took the test, I have a strong automatic association for male with career and for female with family. So, where does that come from? Well, I grew up in the South, and my parents had certain roles, and I think all of the influences in my life sort of conspired to create these biases in me that I'm, consciously unaware of, but may affect my decision making. So in patient care, I think we just have to be aware of these biases against commonly encountered groups. And so look at your practice. If you're a bariatric surgeon, you probably need to be aware of the biases that you may have or may not have about obese patients. You need to increase your awareness at specific times. So for instance, when the treatment course is not straightforward, when you're in high stress or task-loaded situations, and then check your decisions, if it's unclear, against established guidelines. And if you're departing from the guidelines, just think about why. And then it's been shown that increasing diversity in patient care teams can actually improve disparities in patient care. There's a little bit of evidence that doing an educational intervention can be helpful. They looked at 92 departments at University of Wisconsin. They were randomized to no intervention versus a 2.5-hour workshop for a gender bias habit-changing intervention that included a number of components. And they found that in the experimental group, there was an increase in several outcome measures that, including efficacy to engage in gender equity promoting behaviors. However, when 25% or greater of the department attended, the increases in action to promote gender equity were greater. And in the experimental group, people felt like that their research was more valued and they had more comfort in raising personal and professional conflicts. You may have heard this example. In the 1950s in the United States, I don't know how many of you are aware that orchestras were almost all men. And around that time, the Boston Symphony wondered about this and began to conduct blind auditions. And they were followed by the majority of major U.S. symphonies in the 70s and 80s. And the proportion of women in these major orchestras today is now 30 to 50%, with much of the increase has been attributed to blind auditions. They found that with a blind audition, women were more than 50% more likely to advance to the final round and 3 times more likely to get the job. However, these numbers were initially lower until they asked performers to audition without shoes. Why do you think that matters? Does anybody know why shoes would matter? Heels, yeah. So they found that sometimes when women auditioned, people knew knew that they were women because they could hear their high heels clicking on the floor. And so obviously it's difficult to use an intervention like this to screen residents or students differently. It's not really a way to do a blind audition for being a surgery resident, but I think it is informative that making these changes can influence our hiring decisions. And then we can level the playing field. We can incorporate fair screening tools, so we can pre-commit to specific credentials before we start reviewing applications. I think we have to carefully consider personal statements and letters of reference because there are many data that show that these are inherently biased. You can familiarize, if you're on the committee to choose residents at this institution, you can ask Dr. Giles, what screening methods do we use? And how are those screening methods designed so that we avoid bias? You can have an inclusive interviewing team. And then something we're sort of experimenting with at Wake Forest is using structured interviews. And so you create an interview that has a question that has a standardized set of responses and a scoring system so that your interview depends less on, for instance, with Dr. Giles, whether or not you can talk baseball with him and more on your standardized response to a particular question. But I think really the key here is that we should not feel guilty about our implicit biases. That was how I felt when I started looking at my own results on these tests and at all these data. But I think that doesn't help because, as this quote says, guilt tends toward inaction. I think we have to just be consciously aware of our biases, minimize them as much as we can, and then just constantly check in with ourselves to ensure that we're acting based on our Mr. Spock rational assessment brain of the situation rather than on stereotypes and prejudice. So in conclusion, implicit bias is pervasive, and there is evidence that it affects our interactions with patients and our trainees and our colleagues. There are strategies for awareness and structured interventions that can help mitigate the effects, and I'm sure that there will be more forthcoming in the literature. And these are sort of my quick reference resources. Blind Spot is a fantastic book, if you want to learn more about this, by Banaji and Greenwald. The New York Times has an excellent website that has some mini videos that kind of help you understand some of these concepts. And then looking at the screening and hiring decisions in particular, the AAMC has a webinar and a number of resources that can also be helpful, and there's a link on these slides. And I'll make the slides available to anybody that's interested. So and I'm very honored to be asked to speak here today, and thank you very much. I'd be happy to answer any questions.
Really excellent questions here. Hold on, Dr. Beard. Let me get this for you. Let's get you started here. Let me have it.
Thanks, Amy, for coming back here. You were the last class that I did interviews for candidates, and I was impressed with you when you came here as a medical student. Two classes of patients that I can think of just as you're talking, that is a non-compliant patient that you just feel like you're done with them, and then the ones who's unappreciative of what you do for them. To me, those automatically become people that are difficult to be fair and to try to be aggressive with their treatment. I guess just know that it's there is probably what you're talking about, so I don't know if that's something that they looked at or something you've thought about or.
Well, yeah, I think those are tough patients, and you realize that you may have some explicit as well as implicit biases against treating those patients because it's hard to treat somebody that you feel like is not receptive to your treatment strategies. I think one approach might be to try to delve more into the reasons for noncompliance and realize that there may be, especially in a patient with a different gender or ethnicity than you, there may be some of the physician-patient interactions that are difficult because you don't share a common background or frame of reference. And so, I don't know, obviously I take care of trauma and acute care surgery patients, and they are all the time doing things that I think are unwise and ill-advised. And when I'm struggling with that, I try to think about all of the social determinants of health and the things that may contribute to getting them to where they are before they got to me that may be influencing their compliance with my treatment plan. So, but it's hard. I can empathize.
Maybe a summary statement of to some extent that answers that is I have to remind myself all the time and frequently remind students and residents that crazy people get sick too. It's just like, remember TB and occult appendicitis and things like that when you're a surgeon. But one of them is crazy people get sick. And those patients that you don't like get sick. And so I have to double down myself in those patients to be sure that I am trying to be as objective about what they're telling me and what I'm seeing, because I don't have to be that objective with somebody I like, it seems to me, because I'm going to be very comfortable with what I do.
I think you just described an important strategy, Dr. Burns, this sort of when you come to a moment where you realize that you might have a bias, slowing down, taking a second to sort of check yourself.
Because I have a bias about somebody that irritates me, like Dr. Greer, and I admit it freely, and sometimes admit it to the patient, but I'll still try to take care of them. You can find another doctor, you can't be everybody's doctor, and maybe you just need to find someone who understands you better. Which I guess that's one of the points that I wondered about in some of this, not to question any of it, but I think myself, I wondered about the fact that just inherently we are more comfortable communicating with somebody who has a similar background to us. And you can't help but that become a factor in how you evaluate your relationship with them, and then you get kind of paranoid about what they think. I mean, I know I leave the room sometimes paranoid that I really realize I walked out of the room and that patient thinks, God, is he a goofus, But I think part of that is because of your background, and you can't help your background, in that regard. Did you run across things where to try to analyze your own, you showed us the test to take yourself. What about your basic personality test? Because, personality tests don't really test your bias. They test how you react and how you think. I know just having done one myself for this coaching project that the college has, we had a variety of people in the room, including women and African Americans, and yet personality types shifted just about like you expected them to be. What about that? Any reference to that in terms of how it might be less or more difficult for you and in your implicit?
Oh, that's interesting. I don't think anybody's ever looked at results on any one of the major personality tests in relationship to their tendency toward any implicit bias. But that's sort of an interesting concept. Maybe someone should look at it.
Well, I think it goes hand in hand with your. I'll bet you that your basic personality. If you take those tests, and apparently they're like your IQ, they don't really change. Once you're an adult, your basic personality is going to be the same. It's like Dr. Stone used to say, leopards don't change their spots. And that's one of those things that I think is true. But I wonder if I put those two together. Yes.
First of all, I think it was a great presentation, and I appreciate you coming today. I wonder if you've done anything or seen any data on what I'll call maturing bias, maybe otherwise labeled as cynicism. An example of my personal experience is when I was in medical school, I thought surgery represented the kind of the last stop for trauma victims arriving in the ER. These were innocent people who were, reading the Bible, sitting on the front porch when they were shot. And my cynicism after residency, I'll use that word, when I realized that these were people who had surgical scars many times, they participated in high-risk behavior multiple times, and I had the opportunity to see many trauma victims multiple times, even during my short stint in residency. And when I got into the community, it was a similar thing. There were a certain group of high-risk participants who I saw multiple times during my time in private practice. So I readily admit that, because as I would talk to medical students, I gave them that scenario. I said that, in my experience, most trauma victims are, in fact, not innocent bystanders. They're very rare. Do I see, these trauma victims, but rather people who the statistical odds have kind of caught up with. And I realize now, in retrospect, the statement that I made to those people was a bias that I developed through my training. So, could you speak to this bias that we perhaps developed during our training, from our experiences as surgery residents and surgeons in general?
Well, there aren't any data specifically about surgeons looking at what you're describing, the biases changing as you go through your surgical practice. But there are data in the literature that say that you're that one of the only things that can actually change your results in these implicit association tests are actually interactions, direct personal interactions with people who are in groups about whom you harbor some implicit bias. And so I think that could probably go either way. And so if you have experiences with people in groups against whom you're biased that teach you something about them that is favorable, then obviously there's a potential for your IAT results to shift in a favorable direction. And then if you have experiences like what you're describing that are, potentially unfavorable, then your test may sway the other direction. I actually, it's interesting because I've had sort of the opposite evolution in my approach to trauma patients over my career. I think I'm working on some coursework for a master's in public health, and have thought a lot about sort of the social determinants of health and some of the things that contribute to our trauma patients becoming trauma patients before they, do the stupid thing that gets them in the car accident. And I think I've actually become more favorably biased toward my patients than I was in the past. And so I just think it depends on your frame of reference and what experiences you have.
I think I'd have to admit that I've been guilty of saying before, most people who get shot or stabbed deserve to get shot or stabbed. This level of cynicism, that you just expressed, Dr. Murray. I mean, I hate to admit it, but I mean, that is, after you do a lot of it, you can't help but.
And this is the penetrating trauma are the ones that the blunt trauma I think do fall in it. But I think they're a different group, but the penetrating trauma specifically was I was speaking to.
Yeah, Dr. Valier.
Dr. Amy Hildreth, facts.
Thank you, Dr. Pai.
Not to call you Amy, not to show my biases, as you represented. Thank you for coming back.
It's taking a while for you to get there.
Well, yeah. Well, just not to show my bias. I'm trying to fight it. For me, Amy is wonderful. Anyway, but how can you tell your explicit bias are not a manifestation of your implicit bias expressing? I have a hard. Now I'm going to have to question every bias I have. Is it an implicit bias or an explicit bias?
Well, I think if somebody gave you a survey that was anonymous and you would answer honestly that you had a bias, then that's an explicit bias. That's easy. If you on a survey that was completely anonymous, you thought no one was ever going to see, would answer that you like chocolate as much as you like gummy bears, then if you answered that and then you took an IAT test and it showed you that your results were different, then that's clearly an implicit bias. I think the implicit biases are the things that are just completely not congruent with the beliefs that we say that we hold and that in ways that we believe we would act.
Okay, I want to continue this discussion a little bit here. I want to tell you a story to follow up on Dr. Murray's point, though. When I was a senior level resident, this was sort of in the era when, for lack of a better term, flower childs were coming along, and we had this young man who had been a medical student who became an intern. And in the emergency room at the Gaston, he would take you in and wanted to be sure you introduced you to all these patients, gunshot wounds and everything. Now, Dr. Burns, this is Mr. Jackson, and so forth and so on. And so he was at the height of being sure that he treated everybody the same. 2 weeks into his time in the emergency room, I walked past the room, and he was a big, strong guy, had long hair and everything, but he had a patient down on the stretcher with his arms pinned, hitting him in the face because he had just turned directly, and from that point on, his level of cynicism switched, just like you said. So I had to drag him off this guy. So, and this is after going from that. Now, you touched on something I want you to elaborate on us, because it's the issue of, I want to make one other point before I forget. The blind audition, we're proud of Chattanooga. The maestro and director of the Chattanooga Symphony is a woman. So, just so you know. And I don't know if that came from a blind audition, but she really is very good. The interview process, because that, for all these years now, we've worked and tried to perfect that, and yet we realize it's really not perfect. What about that? What kind of changes or secrets do you have that could help us in that regard?
So, interview process for surgery residency, I think, is tough because it's two things, right? It's you're trying to pick people who are going to be good in your residency program, but it's also sort of a recruiting thing. And so I think the visit is it has a dual purpose. And so when it comes to evaluating people you've already decided to interview, you can't have blind auditions. You can't have interviews that are all structured questions, because that's going to turn off applicants. I mean, really, we're trying to attract the best applicants to our program, and we're probably all interviewing the same pool of really talented applicants. And so we can't have things happen in our interviews that are so, I guess, taxing to the interviewees that they don't want to come to our program. So it's kind of, it's hard. And what we've chosen to do is just one of our interview rooms is a standardized question, and the rest of the rooms are just, same old, just a conversation. When it comes to screening, I'm pretty intentional about making sure that I have, the study that I showed you where varying the percentage of people in your pool varies the scores of that particular group. And so I've just tried to make sure that I am interviewing a pool that is diverse enough that there's a chance that we will attract a diverse group of residents, and really the chips fall where they're going to, because really it's the applicant's choice. The match favors the applicant, and I think I try to show that we've created an environment that is welcoming of all types of diversity of opinion, diversity of ethnicity and gender, et cetera. And I think that I do the best I can to sort of show that we've created that environment, and then the applicants choose. But I think the thing that I do intentionally is really look, once I've decided who to interview, and make sure that I have decided to interview as diverse an applicant pool as I can.
So selecting the interviewees, you can do that. You can make that diverse, because they do have an application or a picture or something. You can do that.
Right.
But
Yeah,
how
but
do you
they have
pick
a stated
between them
ethnicity on
which
there.
one is likely to be
Yeah,
the
you
name
can't.
Hildreth at the end of 5 or 6 years?
The other thing that we are intentional about is having the people who interview at our program making sure that we have a diverse representation of both specialties, gender, ethnicity, and different, just people with different personality types interviewing. We have people who I would consider introverts, people who I would consider extroverts also interviewing, to try to make people feel like that at least one of their interview experiences, they feel welcomed. Hopefully all of them, but not everybody can click with everyone.
Well, Dr. Hildreth, we are really proud of you being here and showing us what a scholarly approach you've taken to a difficult problem. This has been a great talk as far as I'm concerned. I just think it's tremendous. We're also proud of the fact that she is increasingly recognized on a regional and national level, and make us look awfully good. So thank you very much for that, and thank you for being here.
Thank you, Deb Burns.